at least about some of it. The title is a little alarming, but you will probably be following me, and maybe I'll try to convince you. So basically, these are my disclosures. I'm involved in a lot of startups. This is probably not completely updated. In my career as a surgeon, I've been involved in 18 startup companies in the field of medical devices, most of them involving operating technologies. And these are the companies. You see the ones in blue are companies that were already sold or went public. The ones in green are active companies. And the one in blacks are companies that are dying or dead. This is how it is. Actually, it's quite a good success rate for startups, especially in Israel. What I'm going to speak about is a little similar to what this dinosaur is saying. My claim is that our profession is going, mostly a lot of it will become irrelevant in a decade or two. And we have to prepare for that and change for that and be agile. So surgery will still continue as a trade. So basically, I'm going to define what surgery and why it will be disrupted. I'm going to speak a little about new interventional techniques, what will happen in the near future, what I think will happen a little later, and if there's anything we can do about it, what we should do about it. Basically, surgery is mechanical manipulation of tissues. Surgery is a simple profession in terms of the philosophy behind it. We remove diseased tissues. We reconstruct damages, either made by us or by nature or by other people, like trauma and car accidents and attempted murders and wars and stuff like that. And we try to fix the damage that we have done. If you look at the type of procedures that are done in the operating room, you will actually notice that we can broadly divide them into two groups of diseases and two groups of procedures. The one group is organ or structural problems, which means a disease that involves a specific organ. And this is mostly mechanical problems, trauma, wear and tear, valves, hernias, congenital malformations, etc. And these can probably, mechanical problems could be only fixed by mechanical means. So I think that if you're an orthopedic surgeon or dealing with cardiology for quite a while, you will still be busy and have no problem using more or less technologies, but doing essentially the same. On the other hand, most of the diseases that are being treated by surgeons are diseases that are basically based on cellular diseases. It used to be infection, where bacteria or other microorganisms infect tissues, or cancer, which is actually a cellular-based disease. The fact that somebody has cancer in his liver is not a disease of the liver, it's cancer in the liver. The basic disease is from a cellular basis. If you look at the history of surgery, you will remember that most of what surgeons did until about 100 years ago was treat infections. They took out teeth, they treated boils, hemorrhoids, and then tuberculosis, and then gastric and duodenal ulcer that stopped being surgical diseases, and now diverticulitis is not a surgical disease except for extreme cases, and appendicitis is slowly dwindling away. So basically, infection is almost off the chart. And cancer is beginning a very similar course. So we're going to see less cancer because we have more prevention. People smoke less. We're fighting pollution. There's a lot of early detection. We're doing a lot of screenings in breast and colon and gastric cancer around the world. There are a lot of new drugs and genetic engineering and biological drugs and things that enable us to treat cancer on a cellular basis and not on the organ basis. And if you look at the charts from around the world, you can actually see the numbers show it. You know, the incidence of stomach cancer is declining, the incidence of colorectal cancer is declining, both incidence and death. The incidence of lung cancer, death is declining. The only cancer that is on the uprising is breast cancer, probably because a lot of early detection, because the death rate keeps on dropping. So basically, cancer is becoming slowly less prevalent. So this will actually create a paradigm shift. I think that what will happen is that procedures will move away from traditional surgery, procedures will move out of the operating room, and we will be using a lot more technology to do this. Now, what I'm going to do is to try and predict what will happen in the near future, and then to predict what will happen a little further away. And if we'll meet in 20 years, you can tell me if I was right or wrong. So now we're going into the new step, which is I call the step of different surgery. A lot of surgical robots, a lot of new technologies. And the next step will be a little more obscure, and I will talk about it. So basically, this is a nice animation from the University of Twente looking at what they think will be surgical robotics. And you see the surgeon is sitting in this high-tech console, driving remotely a robotic flexible endoscope, using sophisticated augmented reality glasses. This video was made 5 years ago, so still the surgeon is a man and the nurse is a woman, but the man is dark, so there's a little change. But you can see this, he's robotically controlling a flexible endoscope and removing a polyp from the patient's GI tract. And then it's removed, and then he turns his attention to another room where there is a surgical robot suspiciously looking like a Da Vinci system, where he controls the robot. You can see he has a screen that shows him all the data of the patient, and he can continue the operation in the next surgery. I think this is not going to happen. So currently we have basically 99% of surgical robots in the world are this console, which is with us since 1997 and is dominating the robotic surgery market. Although this makes a lot of noise, there are probably 5,000 or in this area of Da Vinci systems in the world. There's about 200,000 operating rooms in the world. So we're about 2.5% of operating rooms have a Da Vinci system, which is not, and I mean, it's something that people talk a lot about it, but this is not mainstream surgery around the world, especially not in, I'm not speaking about the United States, even not in, especially not in lower income countries. It does amazing things. This is the single port system, but it's all based on a console. The surgeon is sitting on the side. The console is a big, bulky system that sits in the operating room, needs to be docked, undocked, lots of stuff going around, then very, very expensive. And this is more or less like owning a Bugatti Veyron. Bugatti Veyron is a car that costs more or less like a Da Vinci system. It's about 2 million euros. It's beautiful to drive. It's a lot of fun. It's ergonomic. People look at you when you do it, but basically it still drives you from one place to another, and it needs a driver. And the Da Vinci robot is the same. It's fantastic. It's amazing technology. It does a lot of good stuff, but basically it operates the same operations that we used to do without the robot. And it needs a surgeon to do the procedure. The surgeon still control 100% of the work. It's basically, if you look at what truly a robot is an information machine. A robot is something that can take a fantastic computer and translate its brain into motion. And currently, we're not really working with real robots. And I think the fate of robots that are autonomous robots for surgery is going to be very much like the fate of self-driving cars. It creates a lot of hype, but the decisions that the system should make are not only mechanical decisions. There are a lot of ethical decisions. For instance, if a car needs to make a choice between hitting a wall, hitting a dog, or hitting 3 workers, who is going to take responsibility on the choice the car made? The car maker, the guy who wrote the software, or the driver who was completely asleep? So I think that looking into doing autonomous surgery is something that will take a very long time. And by that time, I think a lot of what we do today as surgeon is going to be completely different and will require a completely different set of decision making. There are a lot of other robotic systems that are close to the market or almost in the market or into the market and then went bankrupt. Most of them are based on the same idea, which is a console procedure where the surgeon is controlling the system from the side, either via single port or multiple port procedures. There's a newly introduced Versus system that is already installed in a few places around the world, and people are really excited about it. But basically, it's the economical model is a little more nicer, but it is the same system. We know that both Medtronic and Verb, which is Johnson & Johnson and Google company, already stated about 8 years ago that they're going to come soon into the market with a robotic system. And so far it's being postponed continuously. Nothing really happens. We don't know. It's probably very difficult to do something ambitious and different from what's on the market. But if you break down what the robots give you today, they basically give you two amazing things or two important things. One is a very, very high level 3D visualization that enables you to do complex procedures easily. And the second is articulation, but this articulation could be achieved in many ways. This, for instance, is a mechanical system that does it, a little problematic, but still something that can work. And this is a system that we've done in Israel. This is Human Extensions robotic system, robotized laparoscopic instrument. You hold it in your hand. I will give a little talk about it a little later, showing you exactly what it is. So to get articulation and 3D vision, you don't really need to buy a large console. You can create your own plug and play system. You can buy a robotized arm and off the shelf Olympus or Storos or anybody else Stryker 3D system. And then you can create your own plug and play robotic system that will cost you about 10% of a Da Vinci, and you can use it very easily. But when you think about a robot, you think of something that performs better than humans. You want a robot that will perform better. This is a nice project by a PhD student from Tokyo University of a robot that always wins. The reason is that the robot is much faster and reacts to the tester's motion. And there are some systems that can use artificial intelligence and robotic systems to stabilize your vision. This is a nice system that was an Israeli company that I was involved with that is focusing the camera automatically on the instruments in the abdominal cavity. This system was bought by one of the robotic companies, now implemented within the robotic system. And there will be more robots coming, cheaper, smaller, task-specific, semi-autonomous, bed-mounted and handheld. There will be a lot of robots coming very soon into the market. And there are also small pill cams that can do all kinds of crazy things inside your GI tract, take pictures, take biopsies autonomically, anchor themselves to mark the spot, etc. And if you think of what surgeons should do, you have to think about our peers. There are good examples of professions that embrace technologies. Gynecology surgeon do ultrasound, endoscopy, ablation. Urologists do endoscopy, image-guided procedures. Robotics, vascular surgeons do laser and image-guided procedures. And orthopedic surgeons use robotics and navigation freely. A bad example is cardiac surgeons who refused to go into catheterization 30 years ago and said after almost all the coronary bypasses left them, they said, okay, but still valves will be there. And now almost all the valves are also done transcatheter, and there are about 10% the number of cardiac surgeons as there used to be in the early 90s. So multiple surgical robots, and the next step will be what I call the yin and yang revolution, which I think this is exciting. This is what we should be ready for. You know that in Chinese medicine, the human organs are divided to two groups, solid organs and hollow organs. Solid organs are yin organs and hollow organs are yang organs. And I think that what we were going to see is something similar to that. In hollow organs, we're going to see more and more endoscopy and catheters and capsules that will treat the organs from within. In solid organs, we will see a lot of use of ablation and directed energy to ablate pathologies. And I will go into it a little bit. If you think about endoscopy was started 50 years ago or 60 years ago, but only as a diagnostic tool. And then they started treating bleeding and strictures, and then ESD, and now endoscopic sleeve gastroplasty, etc. So a lot of things are happening using flexible endoscopy in the GI tract. There's no really reason today to do endoscopy for diagnosis. You can do it using imaging quite well. And even very soon, I think we'll be going to see better testing tools like DNA, fecal DNA, that will help you diagnose polyps and cancer in the GI tract by stool tests, and even blood tests that are now looking into fragments of RNA and DNA, cancer DNA and RNA. And I think in a few years, we'll be able to start diagnosing cancer, GI cancer, from different blood tests and stool tests. So for diagnosis, this will be a tool that will slowly go away. People will do endoscopy and gastroscopy and colonoscopy only as a therapeutic tool after a preliminary diagnosis was already made. And you can do a lot of stuff today, especially in Asia, but now everywhere they do removal of large superficial tumors, they do POEMs, they do ESD, they do bariatric procedures, suturing, etc. But the problem is that the tool that is being done, that everything is done with, is still the same. We're still using this primitive endoscope that was designed 50 years ago with hardly any changes. This is an attempt to do a transvaginal cholecystectomy using a flexible endoscope, a procedure that took about 4.5, 5 hours. And was and used about 4 people driving the endoscope. The reason is that the scope is completely ungeared for this type of procedures. And this is more or less like trying to win a race today using this car. You know, the car didn't change, but the world has, and we need to start thinking about that. And what I always say that doing endoscopy is like having one eye and tweezers on top of your head, and you're asked to do very complex procedures using this tool. This is how a flexible endoscope is working today. And we're beginning to see solutions to that I think will change this world, which is robotized systems. This is a system from Singapore. There's already a better generation of that, which is a robotized flexible endoscope that you can do ESD and resections of full thickness bowel wall with. This is a very nice project from the University of Twente of driving an endoscope using a motorized system. And this is a project that is done with the collaboration of Storz and EarCAD, robotizing a shorter endoscope. And you will see soon that using this endoscope, an untrained technicians who has never done this procedure before performs a very nice ESD in about 20 minutes, just because he has articulation, 3D vision, and a stable system that allows him to do the procedures. So if you want to go into robotics, I think this is the world where we should really do something bold and interesting. And I think that surgeons should go this way. I think this is surgery. This is not just endoscopy. And you can actually use the same system for single port procedures in the abdomen. This is, of course, a pig. So everything will go into the tube, like cardiac surgery, GI surgery, urology. A lot of procedures will go inside the tube. And if you think of it, a lot of the GI tract can also be a highway to different organs outside the GI tract. Many organs in our abdomen are close, very close to the GI tract. You can exit the stomach or the small bowel and get to very easily to the adrenal, to the kidney, to the liver, pancreas, gallbladder, etc. And all these things will replace surgery. So the missing part for this revolution to occur are navigation. Where am I? If I want to exit the GI tract, how close I am to an organ. EUS is used today, but it's still a complex tool. How to drive the endoscope easily, not with all these wheels. Provide a stable working platform. Tools that can destroy tissues well, and tools to remove tissues well. We're still not there, but we're slowly getting there. This is a, sorry. This is a system that was bought by J&J, which is a system to navigate an flexible endoscope bronchoscope. It looks like a primitive thing. It only has a needle, but for many lung tumors, you don't need anything but a needle. You can biopsy with a needle and you can ablate with a needle, and the tumor will be gone because you can burn the tumor in situ. So this is, I think, would be a revolution in lung cancer. You can also get to tumors via blood vessels. This is a startup company from Israel that you can catheterize into a through a blood vessel into a tumor and ablate the tumor in the liver. The real goal of our procedures is to destroy all cancer cells, and not to remove everything out. We just need to be dead, so we have to make sure that all cancer cells are dead, and we have to prove that they're dead, that's all. So the future of endoscopy will be away from complex procedures. They'll be complex in nature, but simple to perform, and ablation of tumors, I think, will slowly take over the idea of removing tumors. The obstacles, of course, are gastroenterologists and radiologists that control the technology, and differences between countries and hospitals of what surgeons are allowed and can train for. All the solid organs will be used more, will be ablated more by directed energy. Peripheral targets are better approached from the surface. The advantage is that it's simple, straight, and accessible. The disadvantages are that our skin and subcutaneous tissues are the alarm system of the world of our body, and that it needs a lot of equipment. And when you look into more complex, sophisticated imaging systems like CT and MRI, these are big furniture that sit in the geographical domain of radiologists, and it's very difficult to get access to surgeons to these places. This is Rick Satava, a genius surgeon who came up with this word, with this idea of directed energy, and a lot of other things. He's probably the visionary behind the robotic systems as well. You can use different types of energies: heat, microwave, cryo, focused ultrasound, and focused radiation. All of them can destroy tissues in a very controlled way. And you can do that very well. You can destroy tumors very close to even the heart, in the liver, in the kidney, and you can make sure that these go away as long as you do it well. This can replace surgery. For instance, in hepatic tumors smaller than 5 centimeters, most of the places report results that are similar between surgery and ablation. So this is one step in that direction. And in breast cancer or breast tumors, you can actually replace removing the tumor by a cryo ablation of the tumor. This is a trial this is an office procedures under local anesthesia. You can freeze, this is another Israeli company, by the way, iSecure. You can freeze the tumor in a very controlled way under ultrasound. The system will tell you when the tumor is completely dead. And it takes about 20-25 minutes. The patient goes home after 5 minutes, 10 minutes, and the procedure is done. So you can say this is a good procedure for benign tumors, but actually the company just completed a large study on small breast cancers, and the results are exactly the same as surgery. And if you look at a possibility of accessing lymph node, axillary lymph node staging, axillary lymph nodes with ultrasound, and final aspiration of lymph nodes, you can understand that the days of radical surgery in breast are almost gone. Of course, you can have fantastic equipment for all kinds of procedures, but you can also robotize this. So this is another company that robotized a needle insertion. It can do it much better than humans. It can triangulate and move the needle in ways that can manipulate the tissue and bypass important organs. And this is also done today in real life. It's a little hard to follow this video, but you can see that the needle goes in and completely avoids hitting the little beans and then hits the bean at the tip. And it allows you to do ablations and biopsies in deep places, avoiding hitting important organs. Again, much better than humans, robotized system, removing tumors in a way, but not real surgery. And if you think that ultrasound is this, but it's also becoming this, you can understand that surgeons need to start controlling ultrasound very well and using it on a day-to-day basis, both for diagnostic procedures and for intervention. So imaging will stop being a diagnostic profession. Using of AI will enable interpretation very easily. Devices will be used more and more by interventionalists at point of care, and it will become an integral part of interventional technologies. And what we need is not only a map to show us where to go, but we need an interactive map that will show us something like this. And this is already becoming available in orthopedics. These are augmented reality glasses that project your location and the patient's anatomy in front of your eyes and allow you to do complex procedures without looking at the screen, but with looking at an augmented reality image. And if you think of all these imaging devices, the glasses that come into the market, I'm sure that in a few years we'll be able to use them directly in the operating room. So what will happen is that minimally invasive surgery is going to even move into non-invasive surgery. Focus ultrasound, something that has been around for about 10 years, allows us to focus energy on tumors under MRI. You can remove breast tumors, you can remove fibroids, and you can even remove ablate prostate cancer when you put an ultrasound probe into your rectum. The probe has a diagnostic head and a therapeutic head. After you scan, after the prostate tumor is scanned, the borders are identified, the nerves are identified, the urethra is identified. You replace the scanning probe with an ablation probe, and you can start ablating the tumor and removing the tumor with non-invasive surgery. There are already systems like that coming to the market now, and I think they will kill a lot of the surgical procedures done for prostate cancer. To be involved in ablation, interventionists have to master imaging. It's only a technology, something that we can go into. Many interventions, remember, were invented by surgeons. It's a tool like anything else, and it's sometimes you can make miracles with it. We need to fight our way into this. There's a lot of turf war. I would start with breast, abdomen, hernia, and trauma. If you think of it, basically what's going to happen is that surgery, endoscopy, and catheter-based procedures are going to merge into disease-based interventional team that will treat patients in different technologies depending on the severity and the scope of their disease. The surgeon is going to become different. You need less manual skills, less authority, less guessing, and less individual performance. There will be teams of people who work together and doing fantastic things to the patients in a fantastic way. There will be more confidence, more help in decision-making, more collaborative and teamwork, and more time for interaction and counseling with our patients and our peers. We need to break all these silos before we can do this. It doesn't make sense that radiologists, surgeons, GI, cardiologists all work in different silos. And you know that when you remove the barriers between enemies, they stop becoming enemies. You can learn that from the animal kingdom. You see that once the fence is gone, they lose interest. Humans are the same. When the borders will be gone, we have to work with each other. We can start collaborating on treating what we're really there for, which is treating patients. Where should we go from here? We should adopt catheter and flexible endoscopy. We should adopt imaging, especially ultrasound. We should play with smart robots and understand what to do it. Be database and connected and use imaging freely. We will need to build disease-oriented teams, not departments, and patient-centered strategies of treatment. And always remember hypocritical oath, and that our commitment is not only to our patients and also to our community. And our community, as for now, is planet Earth. So we can't use resources crazily. We can't spend money on nice toys when other people don't even have antibiotics. We have to be conscious of the use of energy and waste as well. We have to be proactive and not let our lack of knowledge or skill to determine our careers. We have to think about cost effectiveness, risk benefit, and value for the patient and the society. So to conclude, surgery is mechanical manipulation of tissues. Many of the current manipulations will cease to exist in the near future or far future. The rest can change dramatically, and we all have to embrace change and be very, very proactive about it. And there are a lot of things that augment our abilities: augmented vision, augmented hearing, augmented motion. All these things can allow us to become super surgeons and perform fantastic things. And I will finish with my grandfather's immortal words that he told me when I was a child. And I'd like to thank you for the opportunity of speaking to you. Thank you very much.